There is a connection lag.
Yeah, do you hear me?
Roberto?
Do you hear me?
Yes,
Okay, perfect.
yes, we hear you. Come on.
Okay, good morning everyone. Thank you for the introduction. And now we are going to start to do as you saw before, you told it before, that is the basic technique. We wanted to show and to share with you the use of the 8-cone threads. And here we have Sylvie, our model, our patient, that today will be treated with the insertion of the cones to have the jowl definition, the jowl line definition. Now I think you see the patient, and we already marked a little bit the position of the threads to perform a tightening of the lower face and the jowl, and to have a better an improvement as well of the marionette grooves. The pre-marking have to be done with the patient in standing position. I will going to use an angle suture to perform an horizontal traction. So I have to create my entry point over the mandible, over the angle of the mandible. This will be the entry point of the first thread, and then the distal part of the thread will go horizontally parallel to the horizontal branch of the mandible, and I will mark the exit point at 6 centimeters. The reason of this distance, and we will again explain during the presentations this afternoon. And so the first half, the distal part of the thread is in the horizontal branch, and the proximal part go in the preauricular area. Even 6 centimeters, I will find my proximal exit point. So now I need not only the horizontal traction, but even a vertical vector, and I will use the same proximal exit point going to the marionette grooves, and I need 10 centimeters to insert the distance between the two exit points, and in the middle of this line at 5 centimeters I will have my entry point. The reason is because being a bidirectional suture, we have the cones in opposite direction, as I will show you after, and for this reason we need to go in the entry point in the middle of the line. We insert first the first half of the suture, and then from the same entry point the second half of the suture. Now,
Roberto.
Yes, please.
Roberto, one question only. You told 6 centimeters at the mandible line and 5 centimeters from the corner of the mouth to the center. Why shorter or why longer? In that case, in this patient.
Okay. The standard line is normally 10 centimeters to have enough distance between the last cones and the exit point, because we have a compression of the tissue. When I work, for example, if we use 8 cones in the neck or in the jowl, we have more skin excursion, so I'm more comfortable to use 6 than 5, because the traction can be more evident, and to reduce the risk to have the cones that is very close to the exit point. So normally we say that the line have to be minimum 10 centimeters. If it's a little bit more, like here 6 and 6, is better. But minimum 10, because sometimes we have small faces and it's quite difficult to find, for example, for the mid face, 10 centimeters. In this case, we have 10 centimeters, but sometimes we have 8, for example, and so you have to find several tricks to obtain 10 centimeters, like to go behind with the exit point behind the hairline, or to perform a curved line to have 1 centimeter more.
Okay.
In the other side, we do exactly the same.
Can we have a little more zoom?
Yeah. Zoom, please. Okay.
Great.
So this will be the entry point, and this one the exit point. We have 6 centimeters. This is the line where I will insert.
Roberto,
Yes, please.
Is the exit point in the marionette line a little bit forward, backward?
It's not.
Can you explain?
It's not important to have the exit point in the fold or behind or in front, because the cones will work in this position, not here. So the exit point is just to have enough space between the last cones and the dermis. So when I tie it, the cones arrives very close to the exit point and create the traction of the tissues.
Okay, Roberto, but it means for the beginner, if the exit point is a little bit forward, backward, it's not really important. It means it's not a really precise technique.
Exactly.
Great. Thank you.
Pleasure. So, the second line, like before, is from the same exit point of the vertical. Sorry, I didn't paint this one. The second line starts from the exit point of the previous proximal end, and we have 10 centimeters. So our entry point in the middle. This way to mark the line is to treat the lower face area with that we suggest to use just 2 threads with 8 cones. We have the possibility to use, like we will see today and this afternoon, different sutures, but I really would like to show you that the basic technique with 8 cones, how have to be done, because I suggest to a beginner to start with these threads to understand exactly the maneuvers, the traction we have to produce, and how to insert easily a thread. Now, we have to proceed to prepare the patient, and I already did some anesthesia with lidocaine with epinephrine. Anyway, now we disinfect the skin. Usually, we do the procedure in office, And always I start marking the patient. Then I disinfect and I proceed with the injection of the local anesthesia. And then we disinfect again after the injections. And now I start to prepare my table with a sterile drape. I put my instrument that is just a scissor and the 8-inch needle that I will going to show now. And of course, we have to use a small drape. In this case, is not small. Because for transmission...
we don't see very well.
Now immediately. I use usually a standard sterile small drape. I cut a round circle just to leave, don't touch, just to leave the face out, and this permits to have...
Roberto, we have problems with the connection.
Thank you.
The image is not clear.
Image. Imagen. L'immagine no es clara. Now it's okay?
No.
What happened there?
Now it's better, but it's not really fantastic.
But the quality or the
image is not really okay.
Put this.
Go ahead now.
It is better now?
Yeah, it's better.
Okay.
Yes.
Can you turn like this? Perfect. So,
Well, again.
do you see now?
Yes, we would like to have a little more zoom.
Close the field to the face. Don't touch here. Eh? Okay? That is better?
Yes.
This is better? Okay.
Okay.
So, once the pre-marking is done, we just have to do the injection usually in the entry point. And
You go deep or you go superficial?
I go under the dermis and intradermal in the entry point. This because
we don't see very well. It's not Louis Vuitton or Hermes, it's Zara.
is what is not?
The image is not Hermes, it's Zara.
No veo bien.
Now, okay.
The reason of the injection in the deep part and the intradermal area in the entry point, no. In the entry point is to reduce the bleeding in the entry point because we have to go twice with the needle in the same entry point. In the exit point, you can do just an intradermal injection to the patient when we go out through the skin. You don't need to do any anesthesia between the entry point and the exit point because we are in the subcutaneous tissue, in the fat tissue that is not painful, and we can proceed easily until we arrive to our exit point. So, the instruments that usually we need to do the procedure is, first of all, is an 8-inch needle that is provided with the suture that we need to create the entry point in the skin that is the door of the suture to go in the tissue. The thread that we are going to use is an 18-cone suture.
No.
Can you zoom on the thread?
We don't see
Yeah,
very
now,
well.
now we
Can you
zoom.
use the zoom.
More.
Okay.
And when we remove the thread from the packaging, we just have to tighten the knot. And now the suture is ready to be used to insert in this position or in angle path like here to have the horizontal traction. The needles has a little very tiny black line that means the distance between the point and this line is 5 millimeters. This is a mark because, as I will show you, we need to insert the tip minimum 5 millimeters inside the tissue. And so, when we see that disappear the black line inside, we are sure to be in the proper depth. The thread, as I told you, is a bidirectional thread. So we have a first series of cone in one direction and the second series in the other direction. And this is the concept of the bidirectional thread that permits to compress the tissue and maintain the traction. So we start, the only,
Roberto,
yes, please.
are you tightening the thread a little bit to close the knots before introducing the needles?
Yeah, we tighten the suture to close the knot, exactly.
Carefully, huh? Because it's easy.
Yes, it's,
Broken.
it's a 3O polylactic acid, the caliber of the thread. It's quite strong, but of course it's a thread that you can break, so we have to be careful, of course. So now we can proceed with the insertion of the first thread. The first thing we have to do is the entry point. What I suggest to do is just hold the skin firmly and we insert just...
Roberto?
Yes, please.
Roberto, one question. Do you start with the mandible line thread? It's important, or you are able to start with the malar thread? It means it's important or not?
It's not important because always I insert all the suture of one side without any traction. And so if I insert first the angle or the malar is not absolutely important. The important thing is when you do the compression of the tissue that you put traction in the same tissue. So once I insert the tip of the needle inside, I just do a little undermining. That means to move around the tip of the needle just to release the connection of the fat tissue with the board of the entry point. And now we start with the first needle that have to go in the same entry point. You know, we did the 18G hole that is bigger than the caliber of the needle. The needle is 23G, so I feel that the needle dropped down in the entry point because it's thinner. So I put the tip in the entry point, I pin, yeah?
No, we can see well, but not really perfect. The image
The
is
light, I
not
think.
fantastic. But we can see.
But
with the light.
you see with low light, or is the quality of the images?
It's the quality and a little bit the light, but it's the quality.
Prueba a acercar más esta luz. we try to improve the light.
So do you, when you, no, we can see, but we would like to improve the image.
It's dark, it's oscura.
The image is not clear.
It's not clear.
Yeah, now we try to improve the intensity of the light. Anyway, once I insert the needle, you see that the needle is inside in a vertical position respect the skin surface. This is the most important thing we have to keep in mind when we insert the thread, because this is the way to insert the tip of the needle in a proper depth. If the first time is usual to start inserting the needle 45 degrees, so because we use usually the any injection with like filler, for example, we use 45 degrees position of our hand and the syringe. In this way, if we go 45 degrees, we pinch the dermis in oblique way, and then with the other one, if you do the same, we will put the central part of the thread very superficial in the dermis. And this means when we tighten the skin, we can have an entry point dimple. That is what we have to avoid. And to avoid it, we just have to do this, just inserting the tip in the entry point and insert 5 millimeters vertically the needle. Then I turn horizontal the needle and I see that the fat is pulled up by the tip. This is the first check to see that we are in a fat tissue and not in the dermis. And then,
Roberto,
yes,
why you decide to introduce first the jaw line instead the temporal, the vertical one? It's important or doesn't matter?
Absolutely no important. It's just I think it's better to understand the position of the needle in this area. But anyway, you can start with the malar or jowl in the same moment. It's not a problem. There is no priority.
No, it means with the other needle too. With the other needle of the same thread. It doesn't matter.
You say the lower
Go
respect the
vertically
proximal.
Or the lower, yes. Yes.
Okay. No, I do always the distal part always, but there is not really a reason. If for any reason for the position you start with the upper, you can do it. Normally I see that it's easy to explain working in the distal part because we have the standard conditions. And then here, for example, as I wish.
Thanks.
Yeah. And so you see that we have to check where is the tip of the needle, that you see that I can lift the skin with the needle. That means I'm not too deep. And to understand that I'm not too superficial, I just have to see that the needle have to be free under the skin. If I were in the dermis, moving the needle, I create a dimple or a traction of the skin. And this situation is the proper deep depth. So now I have to go maintaining the same depth. I tunnelize in the skin with my finger in the distal part, and I proceed until I arrive to my exit point. Every time I check where is my tip, my tip, and I arrive now to my exit point. I just have to pinch the skin, so I use the needle shield, the protector of the needle, to do the contraction and to pinch the skin. This permits to protect our fingers, and especially in an area where the skin is not very elastic. Yeah, and And especially in the area where the skin is not elastic, you will see that is very useful. Then, especially at the beginning, we can check our depth. You see that I elevate all the needle, and I have to see a smooth surface. That means I didn't pinch the dermis, and the skin is mobile is free over the needle. This is the check that I suggest, especially at the beginning, to do it, because this avoids completely the risk to insert the suture too superficial. Now,
yeah, we can see very well, and we understand, everybody understand that first. We don't need a local anesthesia underneath the skin, okay? You don't need to. Go carefully. If you pinch the muscle, the patient will have some painful.
was painful.
But
No,
it's really easy.
Good.
We see very well. We see very well.
You know, I asked to the patient if felt any pain during the track in the fat tissue, and she told me that it's not painful, because really it is.
Okay,
So
go ahead.
now we have to insert the first 4 cones. I remove the needle and zoom here, zoom here. And now you see that the cone starts to go in near the entry point. The first cone is here. And of course makes resistance. No, quita la mano. Because the cones is the same dimension of the hole, and so what we have to do now is not to force the traction. Now open a little bit, Abba. Now
We see very well,
yes,
Roberto.
and
Don't
so
move the camera.
the risk is to make a traction strongly with the needle in the hand, and this is the way that it is possible to break a thread. So the best is maintaining the traction. You see, I'm maintaining a constant traction with the needle, and I work with my other hand like to cover the cones with the skin. I can do with this hand all the traction I want, and so I don't have the risk to break a suture. And I insert the cone until I see that the distal cones arrive close to the entry point. Now I cut the needle, that I don't need now this needle, and I start to proceed with the second half of the thread that have to go in the upper part, in the preauricular area. So what I have to do is the same thing. I open the entry point, I insert my tip that I feel that is dark. That I feel that is in the entry point because drop down easily, and then I pinch the skin and I insert my 5 millimeters. These 2 steps are very important because it's better like a standard way to proceed. First, you open, you stretch much as possible the skin to see the entry point and to put just the tip, because if you close at the beginning, you close the entry point. And it's very difficult, you don't feel it that really the needle is going in the proper entry point. And so I prefer to stretch the skin, put the needle in the entry point that I feel that is free, then I pinch and insert my 5 millimeters. The reason to pinch is because, especially in other areas, if you pinch, you separate the surface from deep structures. You can have any vessel or something under in the deepness. If you don't pinch the skin, you can deeper and you can create a little bruising that you can avoid it. I'm vertical, respect the skin surface. And now I have to proceed going in the proximal exit point. So I turn horizontal the needle, you know that in this area we have less fat tissue than here. And so the bulging will be a little bit less. And I put in the same line the needle through the line of the exit point to avoid to move then the needle to find the entry point. So I'm the same line. I pinch the skin to maintain the same deepness, the same depth of the needle. And as you see, I check every time where is my tip. I arrive to the exit point, and sometimes you have a very thick skin, and in this area you do not feel exactly where is the tip. So a good thing to do is to use the previous needle. You can put over the other one, and you can check exactly where is the tip. Because sometimes we go over the exit point, the tip may be here, and we try to go out here, it's not possible, so we try to move a lot of the needle, creating the risk to pinch the temporal vessels. Now, I have my needle close to the exit point. I use the shield to do the contraction, and I can check again the position, the depth of the needle.
We see very well.
Perfect. So it is correct. So now I remove the needle. And now you can say here, you can zoom on this area. Okay, we have a loop of the thread.
Yeah, it's great.
Because I'm inserting the second half of the suture, you see the cone start to go to the entry point, and we have this loop. A little check I suggest to do it is to show that from the last cones and the exit point, we have some thread outside of the skin. I hope you see, because if you have the cones very close to the entry point, do not have space to do a rotation, the tip to go inside, and can stuck on the entry point. So now I maintain my traction, and I do the contraction in the skin around the entry point. Here always the needle, the cones have a little bit more resistance when going, because there is the thread coming outside from the entry point and the cones going inside. So sometimes at the beginning the resistance is a little bit bigger. Okay. Now I cut the needle, and this is the way to insert the suture. As you know, I inserted the suture, but I didn't do any traction. What I do is to insert now the second suture, that I will go a little bit faster. And then at the end, I do the traction, but I leave the thread outside that I will trim at the end of the procedure after the check with the patient sitting. Now we proceed with the second thread. I do the entry point, just the tip of the needle, little round undermining. I start with the first needle.
Image is no good now.
The quality is quite oscura. I stretch the skin. You see, even if it's a little bit bleeding, I can feel that I'm in the proper exit point, because you will feel that the needle go in without any resistance. So I stretch the skin, I put the tip inside, I pinch the skin and insert my 5 millimeters. I vertical, respect the skin surface. Then I turn horizontal the needle. Here you see very well that there is a lamp that is the fat pulled up.
We don't see very well, Roberto. We can see, but not really well.
No es
The
que
image
es demasiada
is
luz.
still bad.
Ahí está la, ¿no? Because it's dark or is the quality of the image?
The quality of the image.
La calidad de la imagen es no buena. The transmission.
Se ve borroso.
Ah, borroso se ve. The important thing is to maintain the same deepness. This is something really important. This is the reason because I check where is the tip. I pinch the skin in front of the tip to create a tunnel to maintain the same depth. And I arrive to the exit point. I pinch the skin. I check the skin is totally free over the needle. La mano. And we remove the needle. Cone start to do resistance. I do the control traction, and the first cone are inside. The second half of the thread, I stretch the skin. I insert the tip. It's not.
No, we don't see Roberto.
Yeah, I wait.
1 second. Now, okay.
Vamos con esta.
Yeah,
Then-
go ahead.
Now I stretch the skin. Pardon. And I insert the tip of the entry point. I pinch the skin and I set vertically the needle in a vertical position, my 5 millimeter inside the tissue. Then I have to go to proceed to the proximal exit point. So I turn horizontal the needle and I have to maintain the same deepness. I check every time where is my tip until I arrive to the exit point. I pinch the skin and we can check that all the skin is free over the needle. Now I remove the needle and we start to insert the second half of the thread. The cones make some resistance. I work with the other hand to permit the insertion of the thread.
Thank you.
And this is the way to insert the thread in the jawline with this path. Now what I do a moderate traction. That is holding the thread, and I move the tissue upwards, and I feel, and the patient as well, some click inside. That is the movement of the cone in the tissue. The same thing, the distal part of the second thread. This normally is quite a little bit uncomfortable for the patient to feel these cones moving. And then I need to do the same thing with the proximal end of the thread. This is the vertical one. So I hold the suture and I move the cone upwards. And the same thing with the vertical one. This is the skin compression that is typical of the 8-cone suture. That is the concept of the bidirectional suture. That means fat compression that can produce skin tightening and volumization when we want. But anyway, is the easiest way to insert the thread. This is the reason because we suggest to start using the thread with this thread, and then we can use the 12 or 16 cones in a different path.
Roberto.
Tell me.
Yes. Then you start tractioning the lower part. It means what you really need to lift up. Or you can start tractioning the other cones.
No, I prefer to start with the distal part because I want that the cones go lower as possible. And then with the proximal ends, I will lift it because the concept is that the distal part anchor the tissue and the proximal part fix the tissue.
Okay. Are you over tractioning, Roberto?
No. Usually, as we will show in the presentation this afternoon, I suggest to tighten the tissue until we see the result. We don't need to do over traction. Really, we did it at the beginning, but we create a strong stress on the tissue because we compress a lot the fat and really do not give us better result. The idea was the more you tight, the better, but really is not the concept in the thread. And
okay. Do you cut the threads now, or you wait
no.
until the left side will be done?
Exactly. I leave the suture outside, and I prefer to trim the suture at the end because I check with the patient sitting, and I see if I do some more traction in one side or on the other, and then in that moment I will trim the threads.
Okay, thank you. Go.
Put it
We
on
go
level.
to the other side.
Yeah.
And
Now,
then we will discuss.
you know everything, so we go in a standard manuality. Okay. Perfect, thank you. Okay.
I see.
So I start with the, I put there. ¿Tiene más gasas? Okay. We start creating the entry point. I repeat all the phases. I pinch the skin. The tissue is done. The tissue is strong, so I just insert the tip of the needle, little round undermining, not moving around the needle, just like to mix the sugar in the coffee. And then I stretch the skin, I insert the tip, I pinch the skin, and I insert my 5 millimeters.
Roberto.
Yes, please. Audio stop. No pain.
No pain because anesthesia.
Yeah, sure. The anesthesia is a good invention. They hear me? Yeah? because they are going to make a question, but now we don't have your audio. I hope you hear me. And you know that the needle is vertical respect the skin. I turn horizontal. Sorry, I moved the needle. I repeat, I stretch the skin, I insert my 5 millimeter pinch in the skin, I turn horizontal, and I am in line with the needle to the line to go to the exit point. Sorry, I moved the camera. And we go, yeah. It's painful here?
Yes.
Just one. We arrive to the exit point. Do you hear me now?
Yes.
Okay, because it was a
well.
moment without the audio. This is the elevation of the needle. We see that the skin is smooth, mobile. We don't have any indentation, so it's correct. We just have to remove the needle.
Letter before to compare.
La casa, no? And now we have to insert the cones, making the traction with the other hand, and we cut the needle. The second thread is white. I insert the second half of the suture. I stretch the skin. I put the tip inside, and I insert my 5 millimeters vertically in the same area. Then I turn horizontal the needle. I have the lamp because I'm in the fat tissue. I create my tunnelization. So I follow the needle until I arrive to the exit point, and I pinch the skin. Take this. I remove the needle. Here we have the loop, so the cones start to go in, and we insert totally the thread in the right position. Do you feel it?
Huh?
Pinch?
Good.
Probably we did the anesthesia a little bit too much earlier. So I repeat a little bit.
Yes, if you want.
I won't.
Okay.
Roberto,
Yes, please. Tell me.
you didn't advise the patient not to complain?
It didn't read properly the contract, the consent. No, it's very, very patient. But of course, we are already very early, and the anesthesia probably is a little bit finished. So now I repeat a little bit more the anesthetic, and we can proceed without any problem now. I pinch the skin, I do the entry point, little undermining. Better, no? Isn't it?
Better? Yes.
I stretch the skin. What is the camera? Yeah. I put the needle, the tip needle in the entry point, pinch the skin, and 5 millimeter inside. I remember to you that the malar area is the thicker part of our skin in the face. So sometimes you insert the 5 millimeter, and if you go inside 1 millimeter more, it's not bad. And you have to keep in mind, as I will show this afternoon, that the thicker is the skin, the deeper have to go the tip. Anyway, you can check, like now, with this movement. you see that we have a lamp. For example, I show you,
We see.
if I go in the dermis, like 45 degrees, I don't create any visible lamp because it's in the dermis. And then I will create a strong dimple when I will tighten the suture. So it's very important to stretch the skin, put the tip inside, pinch the skin and go vertical 5 or sometimes 6 millimeters according the deepness, the depth and the thicker skin we have. You see the dimple now is the fat that is pulled up. And now I have the tip here.
We see.
So I pinch here. If I do the tunnel here, really in the lower part is more obliqual, the skin, and I go to the dermis. It's much better to create the tunnel in front of the tip. So you have just to push in a straight way, and you maintain the deepness, the depth, and we don't have to arrive to the dermis that produce pain to the patient and malpositioning of the needle.
But Roberto,
Yes? Tell me.
it's not a problem, the depth. It means if you feel you are more superficial, more close up to the dermis, you move back the needle and then you start again.
Exactly. This is very, very
Means there
important.
is no problem.
Exactly. To understand the real depth you are, first of all, always you have to see, you have to check where is the tip of the needle and have to be mobile. If you don't check the tip, probably you are too deep. And so if you have any idea that you are deep, go back and try again with the needle. This is the first 4 cone inside. And the second are in the same way. We go in I found the entry point, I pinch the skin, I insert my 5-6 millimeters, I turn horizontal the needle, and I proceed in the proximal point, exit point. Of course, it's the same area of the previous one. This is the advantage to do only one anesthesia, only one injection for both. It's not, you don't have to go exactly in the same exit point because it doesn't matter. I see that the skin is mobile, and we insert the second half of the thread. And we do proceed with the tightening, and finally the procedure is done.
Okay, Roberto.
Yeah, please.
Roberto. Well, we learned that it's a fast procedure. It was only, you took 10 minutes to perform the left side. But now,
yeah, the
listen,
left
Roberto.
side.
Listen, Roberto, it is possible to sit the patient before tractioning the left side to compare right and left, and then you can start with the traction of the left side.
Yeah, I did it a little bit. Okay.
Now you go too fast.
Un momentito. Just a minute. Now,
Roberto.
we can sit. Yes, tell me.
Okay.
It means, I think sometimes it's good to sit the patient and tractioning with the patient is sitting, comparing one side and the other, isn't it?
Exactly. Is what we are going to do. No, tiene que ver la cámara. Perfecto. Open a little bit. Open a little. Okay, perfect. We see the mandible. So We did a slight traction at the beginning in the right side. This is just what I think. You know that every time when you see the patient lay down is different than when he's sitting, of course. This is the reason because we do the pre-op marking with the patient sitting. And now what we can see is that this area is tightened a little bit. We can do a little bit more here. This area is straight now. This was a little bit tighter in the lower part, but anyway is a little bit more sagging than this one. I don't know if with the camera we can see.
Can the patient move? Can the patient move the head down a little bit?
Down? No,
Little bit
this
more.
one. Pull
Yes.
down.
Yeah. Okay. Okay.
No,
okay,
not too
okay.
much. Like this?
No, not as much. Yeah.
Like this?
Yeah. We see that the left side is thicker, and the marionette line is visible on the left side, not in the right side.
Yeah, one of the effect of the thread is the stabilization of the tissue, creating anti-gravitational support. So when the patient really makes sometimes this movement, the sagging tissue go down and this one not. And this is apart to have a tightening, so a better, a smoother and a fresher jawline. Now what we have to do is to tighten this side. ¿Que se ponga? Sí, mejor.
Yeah, we see very well. Roberto, go
Okay.
ahead.
I'm moving the tissue upwards. Sorry. I'm not really comfortable to do it, but okay. Sorry. The tightness, when you tighten the tissue, the thread, always you have to hold. You don't have to stretch the upper thread or the lower. Just maintaining in the fixed. What you are moving is the tissue. You are compressing the tissue. And
Roberto,
this makes, yeah? Sorry.
If a cone is getting out through the hole, what do we do if we see a cone outside?
So mainly, first consideration is that probably we did a too small pre-op marking. And so for the next patient, you have to know that you have to do 1 centimeter more. Because if the cones or the knot appear to the exit point, means that the track, the path was too short. And anyway, if you have it, you can tie it, and if you see that the one cone go out, pull it, put out the cone, and cut it at the end. I want to show you one thing. You see that we don't have any dimple in the entry point. Why? This is the reason, because we have to stay in a deep position properly, vertically. This I will repeat every time. Probably, I don't know if after the Dr. Rosalba Russo with the U technique will explain another new procedure with different suture, but I wanted to be to share with you the clear concept to use properly the 8-cone suture in this kind of path. And I suggest really, I suggest really to do this kind of procedure if you are a beginner, just to understand, to know the suture, to have the first contact with the threads. Is much better to use this technique than you can do everything. Because when you do the first suture, really you understand everything. How to tie it, how to move the cones, how to insert the needle. And in my opinion, it's very useful. At the beginning, I did many mistakes. For example, going 45 degrees because the technique was not so clear. And we had a very strong dimple, like you had to wait 3-4 weeks to resolve by itself. So now we have in my opinion, a very easy, quick and effective technique. So really I suggest to start with this kind of path and this kind of thread at the beginning.
Are you going to perform the eyebrow?
Yes. Now I trim the thread.
Okay.
To trim the thread, just I do a little traction on the skin. And I cut at the level of the skin. Be careful with the tip of the scissor. Especially, you see that I do a little traction in the direction of the cones. So when I cut, the little piece of suture is covered by the skin. Gazita. And I try to do systematic cutting of the thread because so I don't forget to leave one. First I do the lower and then the upper. Sometimes the color is I cut it both. I cut it both at the same time. Okay, the entry point was very close. And this one.
Beautiful, Roberto. Thanks
You
a
like?
lot. So much.
Okay, now what I do at the end of the procedure is to put some antibiotic cream in the entry point, and if it's possible to clean the pre-marking that usually when in my private practice I don't do with this marker because it's strong and you have to work. You can just mark even with the white one, just for inject the entry and exit point, then you can follow the whiteness of the vasoconstriction. You don't have to paint again. So thank you, Sylvie. And now we start with Sophie. Sorry.
Thanks a lot.
Thank you, Sophie.
Very.
Okay, we got
No,
to see the eyebrow. Are you going?
Pasamos la otra paciente.
Okay, any question to Dr. Pizzamilio? A few questions because he is going to
¿Puedes
start the eyebrow.
llevarla ahí para limpiarle,
Any
ponerle la
question
crema?
from the audience? We can ask Dr. Pizzamilio when he will come back this afternoon, and he will show us, and we will discuss
¿No está mirando?
about the surgery.
Elio, ¿no está mirando? Sí.
Roberto,
Yes. I'm here.
we go ahead with the eyebrow. Are
Yes.
you ready?
Now we are ready. Now
No,
the
no
patient.
question. We will ask later on.
Sorry?
We will ask questions later on, if there are.
Okay. Can you... ¿Puede quitar? Ah, pero se han ido todas. Eso non lo veía.
Non ti vedo tu. Parlato in italiano, logicamente non mi ha capito.
Silvio. Out?
Know you today
Open.
that the threads are for the beauty, but also you have the possibility to increase the breathing
Miran,
nerves
miran el
with
video
one single soft.
en la sala. Están
It's
mirando
really
nosotros.
a big target of patients coming to your office, not for beauty, for improving the nasal breathing.
Ah, sí.
Sportmen, people who are snoring, that it's fantastic. Now we are able to decrease the number of divorce because people are snoring less. Okay, well, this we will discuss later on. Ladies laughing. Ladies are snoring too. But we are not able to tell our wife, you are snoring because you look at the eyes and you say, you don't like
Están
me."
mirándonos. Están mirándonos.
But some ladies are snoring. Okay, Roberto,
Yes.
we are ready.
Perfect. We have here Nuria, is the second lady, and we are going to perform, I will do now the brow elevation, and then Dr. Rosalba Russo will perform the mid-face, the lower face and neck in the same patient. And when I do the brow with this procedure, when, for example, when we use the botulinum toxin to elevate the brow, we can't elevate the tail of the brow. Try to lift. You see, here we have a narrow frontalis muscle, relax. So even blocking with the botulinum toxin in the central part of the frontalis muscle, we will not have an elevation of the lateral part. So in that case, elevating the tail of the brow can create a nicer aspect of the lateral eyes periocular area. To do this, I use another 8 cone suture, just one each side, and I look for the entry point, that is the traction point.
Emily, unless
That will be this one. This is the only part we have to do a symmetrical position of the exit points, because the suture will be the cones in horizontal inside in the structure of the brow, and the other part will go in the temporal area to fix the brow higher. So the distal part of the cones will grasp the tissue, the proximal part of the cones will fix the tissue, the brow higher. So the distance between the entry point and the exit point have to be only 3 centimeters, because we want that these 3 centimeters, we just insert the cones. And when the last cones will go in, I stop it. The rest of the thread will be through the temporal area and have to be minimum 7 centimeters, because I remember to you that the total distance between the 2 exit points have to be 10 centimeters. So I will have 3 and 7 or 8, because sometimes here we don't have to do a big elevation, but sometimes it's better to put the thread, the proximal exit point at 8 centimeters. You see that we have a little asymmetry of the brow. The right side is a little bit lower.
Roberto.
Yeah?
Roberto, how you decide the vertical line? More vertical, less vertical, more to the temporal area?
Exactly. Is your vector, your finger, that decide where to put the direction of the proximal area, the proximal part, but even the quality of the skin. The lateral you stay, the thicker is the skin and softer. The more medial you stay, you have the bone, and the skin, if it's not quite thick, it's better to stay lateral to have more skin coverage over the cones, to avoid any palpation, any palpability of the cones.
Okay.
Here we have...
To be laterally to the temporal crest.
Exactly. If you stay laterally to the temporal crest, you are in the temporal area with a softer tissue and thicker tissue, and you don't have the hard tissue below that can feel it at the beginning, the edema around the cones, so the patient can say, I feel the cones, but it's edema really, but it's not visible.
Yes, and it is less difficult to move because the periosteum fixed to the bone, the frontal flap.
Exactly. 3 centimeters, and we have 7 here. Now we can start the procedure. I use just 1 thread each side. Now we lay down the patient. Venire un 20 centimetri più in su.
Okay, Roberto.
Yeah. I show you.
Do you have half an hour before the coffee break?
Probably worth to find something to speak, because it will be faster. I repeat the anesthesia. I did before. I suggest every time to do the anesthesia minimum 15 minutes before to have a good vasoconstriction, because in the temporal area we have a lot of superficial vessels. This is the reason, because I inject the entry and the exit points, and I suggest in the brow, like eventually in the lateral part of the neck, over the sternocleidomastoidea when we do the neck, to do each centimeter a little intradermal injection, because this is very sensitive area. and this reduces the sensitivity and improve the vasoconstriction. Non fa male, no? And this is each centimeter along the path. Now it can, el protector. We disinfect the skin. And then after we will do the, at the end I will show the tightening of the brow, and then Dr. Rosalba, after the coffee break, can start with the neck and the jawline.
Yes, and later on today and tomorrow we will discuss about combination, if you use Botox before or after. We have some questions, but will be later on.
¿No tiene un paño más pequeño, edad 7?
¿Es una talla más pequeña?
Un pañito pequeño, ¿no tenemos? Ah, yes.
Me ha dicho una de 8, una de 8, una de 2.
He visto mucho. La que tengo la mano sudada, pero dame esto. So now we start with the 8-cone suture.
Roberto,
Yes?
Roberto,
Yes, please. Tell me.
you go to start right now, but
Yeah.
meanwhile you are starting a question. If you want to lift, means all the eyebrow, middle body, inner body, just the tail, there is any variation about the 3 centimeters?
Yeah. When I want to change the shape of the brow, I can use eventually a U technique with 12 cones. And you can have the position of the horizontal part of the thread according the shape you want to give. Other possibility is to give a more medial position of this L, but we have to be careful with the emergency of the supraorbital nerve. And
Okay, it will be interesting to talk about the variations when you will show in your conference, the eyebrow lift. Okay.
La 8 con esta. I just to show one thing that before I didn't, the packaging of the thread is when we open the last envelope,
It's very, yeah,
is a packaging
very
with
important.
yes, with the 2 thread. I remember to you that the thread when arrive to our office have to be stored in the fridge because the temperature can improve the hydrolysis and makes the suture fragile. So it's very important to store in the fridge between 0 and 8 degrees. When we open the aluminum envelope, the internal envelope is not sterile, so we can take with our not sterile gloves or hands, and then inside this white, the other white envelope, we will find this pack that takes the sterile suture inside. So we can take our thread.
Okay, this is yeah. This is very important. It means this is the typical mistake in workshops. The nurse open the silver envelope and is offering to you the envelope inside. No. The envelope, the second envelope is not sterile. Then you need to open the plastic envelope and to offer you the carton envelope.
Okay, now
Okay.
I have to do exactly what I did before with the other patient. I had to create the entry point, just at the tip of the 8-inch needle, little round under mine, and I start with the first needle.